Hi, everyone. Welcome to Have a Seat. I'm your host, Manny Rodriguez, and I couldn't be more excited to present our very first episode. I think even a little bit more excited about my guest today, Rory Hunter. Rory is the clinical director at La Fuente Hollywood Treatment Center. He's also an LMFT, an LPCC, and a CSAT candidate. He is also a therapist in private practice, and I don't know, I'm just super excited about this. One of the areas in addiction and mental health that has always interested me is what services are being provided and how they're being provided. Why is that important to me? Because I think that when we can better understand that, we probably can provide better interventions for the people that are struggling with addiction and mental health issues. And as a result of that, maybe, just maybe, we could provide better results. And I think at the end of the day, that's what we all want, is we want to make sure that LGBTQ people, and not just LGBTQ people, but all people are receiving services that are effective. So this is just the beginning. We are just scratching the surface, and I think I want to welcome my guest now. Hey, Rory.
Hi, Manny.
How are you?
I'm good. Yeah, I'm good today.
Good. So it's the end of our day. It's been a long day, and I know that there's a lot going on. So thank you for doing this.
The end of the day, but the beginning of this podcast.
Well, thank you. Thank you for saying that. I would like to introduce you to our listeners, to our viewers. I don't want to say I'm a big fan of yours because I don't know how that sounds, but I am definitely someone who's interested in you as a person, as a professional, and as a partner in this work. I have communicated that to you many times. And when I started talking to you about how important having more information and that there was no information, I really felt that you gravitated towards that. And immediately we went to work at this. And I know that this very first report is, as I said, just scratching the surface. But it took us about 2 years to gather information from about 2020 to 2024. Mm-hmm. So I know I said a lot there. So, tell us a little bit.
Yeah, no, it's really exciting to have this data. And whilst, we acknowledge that it's a relatively small data set, it is better than nothing because there is such little data, not just within the addiction medicine field, but with the queer part of that as well. And I think, as queer individuals, we know that there's also not very much data regarding us across the board in many other areas. And, one thing with this data set is that it can both help inform the clinical work, but also help sort of the future and where we're going to go with our program. Understanding the clients we serve much better, the sort of maybe the details that we miss just with clients coming through our doors, that actually once we see patterns emerging through the data, we can actually pick up on a lot more and help a lot more people. This is very exciting.
Can you talk a little bit about the rigorous work that is done before a client is admitted? Because I think a lot of people have this idea that people just show up to their door and they are immediately brought into treatment. But I know that you and your team and admission do it's a very rigorous process, and you look at certain things.
We do, yeah.
And based on those things, scores, etc., you can determine not everything because sometimes people underreport or things can shift pretty quickly. Can you talk a little bit about what that process is like and what are the things that you're looking for?
Yeah, sure. So, La Fuente certainly has more of a rigorous pre-assessment, and that's sort of been brought in out of experience. I think one thing we realized as one of the very few queer treatment centers out there, a lot of people wanted to come to treatment for issues that maybe we couldn't address. So I'm talking more about primary mental health diagnoses. And we are, obviously a primary substance use facility. And whilst we can obviously treat many other co-occurring psychiatric disorders, when it's more high acuity, they need specialized care. And we certainly found when people came who fell into that category, they would obviously have not a perfect experience because we weren't quite the right fit. And we wanted to make sure that we didn't have a negative impact or prevent them maybe for seeking more appropriate care at another facility. So one of the things that we do is that we have three sort of assessment measures that we conduct. One of them is a suicide measure, which is pretty standard. One of them is a personality inventory. So that tends to pick up on those more high acuity personality issues, personality disorders, and also more serious psychiatric concerns, especially with psychosis. Now, obviously, with the clientele that we deal with, psychosis is a common part of their use, but it's more about the underlying issues with psychosis. So is psychosis present when they stop using drugs? So that has been very helpful in teasing out those clients, and also the clients that maybe require more structure around anger and rage. Obviously, we have a lot of clients who come in who have a lot of feelings in that regard, but there does reach a limit where they need sort of more specialized care.
Well, let me see if I can sort of add something here. One of the conversations one of the many conversations that we've had as we were looking at a lot of this information that was gathered and analyzed to some degree is that we can, to some degree, know who might complete and who might not complete.
Right.
And this is just like looking at a substance use disorder diagnosis. One of the things that I remember us having a conversation about was that this could be useful just in terms of how we approach creating that treatment plan.
I mean, it certainly was when I first started at La Fuente 4 years ago, before we had this data, we sort of had a good idea of certain demographic groups that were at higher risk of not completing. And but rather than sort of making that more of a guesswork, we actually wanted to base it within, concrete data. And analyzing that data, we certainly have seen, certain groups that require a little bit more support in those early days. Certainly clients who are younger, they have a lot harder time emotionally regulating just because of their age. Then you add the substance use on top of that. There's often a lot of family trauma, being young and addicted. There's difficult family relationships. And then there are certain gender identity, sexual orientations that have the particular stresses that maybe others don't. I am referring more to the trans community. Again, higher incidences of discrimination, some socioeconomic issues in there too, because it's harder to be employed as a trans person. So they're dealing with different stresses, and therefore that often shows up in their success within treatment.
Right. Well, thank you for that. Okay, well, let's jump into some of this information, and I'm going to focus on the two areas, right, which are who do we serve and completion, right? Can we talk a little bit about what the breakout is in terms of who's shown up in terms of, and I don't know that would differ that much at some other even specific programs. Mm-hmm. So can we talk a little bit about the breakout between like cis and trans, et cetera?
Yeah, it's pretty clear and cut. So it's 75% cisgendered men. It is 23% trans non-binary. So that includes trans males and trans females. They actually break up into 7% and 7%. We have an equal amount coming in. And then we have 2% of cis females. So they're our smallest group.
Can we talk a little bit about the drugs of choice that we have? Because I think that a lot of people think, oh, it's an LGBTQ program, and so it's, the drug of choice for all LGBTQ people would be methamphetamine. So can you talk a little bit about?
Yeah. I think that was one of the surprising things in the data is that we are used to dealing, yes, with a lot of crystal meth addicts, especially since most of our clients, 75% of them are cisgendered men.
Right.
So as it turns out, 53% of our clients have crystal meth issues, and 27% are actually alcohol. So, I think for me, alcohol represented a sort of larger minority than I originally, thought. And, as a small treatment center, is one of the things that I am very proud of, is that we do treat everyone together. And I think that everyone benefits from that also. So, I think there's a lot of stigma attached to certain drugs, especially crystal meth. People unwilling to maybe discuss chemsex issues. But then there is a lot of stigma associated with opiate use, because opiates are not very common within the queer community. So I think opiate addicts who are queer really struggle to sort of find their place as well. We only treat 4% of our clients who come in with opiate addictions, but 4% is still 4%.
Right. And I wanted to just sort of extend this a little bit in terms of programming, and really programming with sort of no separation between drugs of choice. I know that I've had a conversation with you many times about actually that it's a richer experience. And we know, and everyone else in the space knows, that breaking it out doesn't necessarily provide better results, right? And maybe they do, but I don't think there's any data, right? But we just know, based on the work that we do every day, working in real time, this is the only lane that we're in, that it's a richer experience for everyone if everyone is not exposed, but if everyone is participating in the recovery of everyone. I mean, being LGBTQ specific is already enough. So can you just touch on that a little bit?
I do believe that our similarities are more than our differences. Right. And I would say that even with a trans female who's addicted to crystal meth, to a cisgendered man who's addicted to alcohol. Now, obviously, everyone has their different experiences, but ultimately, addiction is an inability to manage stress. Now, what that stress is varies for sure, and certain drugs of choice do a better job at dealing with certain types of stress. But ultimately, there is an inability to be able to show up in life as yourself and sit with your emotions. Now, the way you deal with that differs for sure, but I think that ultimately is what everyone has in common. As an oppressed community as well, we all share that, again, as I said before, in different levels, but everyone can relate to that experience. And another thing that we are very proud of is that we have a huge age range in clients as well. So, and often some of the strongest friendships emerge between the 60-year-old white guy and the Black trans female who's 24, 25. Like, the sort of on the surface, the most unexpected friendships emerge. And that's so beautiful. And I think is a testament not only to the work we do, but just in the recovery community in general.
Let's talk about treatment completion. So I know that we were looking at a lot of information, and one of the things that I really wanted to understand is what percentage of people are completing treatment, and why do we think so? So let's talk about the breakout of the percentage of people who complete treatment, the general breakout.
So it turned out that 67% of our clients complete treatment. So at whatever level of care that they came to join us, some people just stay for residential, some people go through all stages of care, but 67%. And then 33% of clients AMA'd, which means they left the facility against medical advice, or they were administratively discharged for any manner of reasons. And, again, that data is essential for us to really kind of look at, well, how can we improve those numbers? How can we make people stay in treatment longer, complete treatment? And that was where I think the richness of the data really came to stand on its own, because then we could break it out by demographic, age group, drugs of choice, gender identity, sexual orientation. And it was just a treasure trove of information. So I'm really excited see where this goes, because the more data we get to add to this, will the patterns that we have already noticed emerging, certain groups faring better than others, will that still hold as we collect more data?
That's amazing. I'm so excited about that. One of the stats that came out of this that it didn't surprise me, but I just was like, wow, that's interesting, is that our highest completion rate is amongst African American men, and the second highest group is trans men, which I was like, wow, I'm so glad that we know this, because again, we wouldn't have known this had we not done the work. Can you talk, or can you speak to why you think that this is the case?
So this is all theorizing, obviously.
Right.
I think the most surprising out of that was certainly the African American men. Right. I think it was surprising to us because they actually only represent 9% of the clients that come to us, but they seem to fare extremely well. Quite a lot of our African-American clients come through Kaiser. We're an in-network provider with Kaiser. So they have more wraparound care. They, once they finish with us, they go back into the addiction medicine department from the Kaiser they come from. They already have a psychiatrist, potentially a therapist. Maybe they don't see the therapist as much as they would like, but they have that already there. So it removes a lot of the stress that does come from not having those resources available. With our African American clients, socioeconomically, they are different from their white counterparts. I think the pressures on them can be greater than some of our white clients, and so they take treatment more seriously. I think sometimes there's more riding on it, and I think that pressure is not a bad thing at all. I kind of wish some of our other groups had that same kind of pressure, because it would increase their motivation. And I think, that's one reason. I think also with being queer in the Black community traditionally has not been an easy ride. And I think they really find a sense of community and home and family that maybe didn't exist or exist in the way that they needed it to from where they came from.
Wow, I think that is such and we're going to dig deeper into that, because that's what the next round of collecting information is. But even in treatment, right, where, in the world, we know that they have to work harder, they have to prove themselves, they have to be twice as smart to get promotions, et cetera. And in treatment, sometimes they work twice as hard as their counterparts. And the success rate with them, as we've seen, and it's a limited sample, but even in this sample, we see that they are the highest. I think the other interesting data that we have here in terms of completion rate was the second highest completion rate, which were our trans men. I know this is theoretical and we're still digging into data and collecting more. Can you speak to why you might think this is our second highest?
So with the trans male, I'm more confident in my response to this as the reason. I can't be fully held responsible for this insight, because I posed this same question to another clinical director of a different facility who is also a trans male. And he had a great response. Knowing La Fuente very well, he made the comment that we have a majority of cis male clients, and our staff reflects that. We do have more male staff members than we do female. And for trans males, they find that a very affirming environment for them. So I think it really speaks to them being able to feel like they can be themselves and that they're accepted for who they are and they're amongst people that they identify as.
That's amazing. That's really amazing. And I love that we have that information. And I'm really interested in what follows this. That's the thing, because then we know that the programming, interventions, education, et cetera, are the things that follow. Our lowest completion rate is among trans women.
Yes, it is.
So let's talk about that a little bit.
Well, I possibly think for the same reason that I think trans males do so well, the issue then is with not as many female identifying clients and maybe not as many female staff members, they struggle to maybe feel as affirmed as they need to. I also think that the responsibility can't all rest on us and just the sort of demographic mix. I've noticed that our trans females come in with worse trauma histories and more difficult family relationships than their trans male counterparts.
Right.
I think that it is harder a lot of the time to be a trans female in the world because they tend to be, when someone thinks of a trans person, they tend to think of a trans female. When you go on TV and there's a trans character, it tends to be a trans female. But unfortunately, that also means that they become a target more so than trans males. I think it comes down to a sense of misogyny and the patriarchy somewhat, as well as, you know, accepting a trans female within your family than a trans male. So I think all of that sort of comes into it. And, you know, the drugs of choice are different too. So what we noticed is that trans females are more likely to use crystal meth stimulants. Our trans males are more likely to use downers, so alcohol and opiates as well. So their ability to sit with their emotions are very different, whilst crystal meth addicts have a real trouble regulating their emotions. The cravings and the triggers are that much more intense. I think there is often more of a history of sex work with our trans females, but also our gay men who use meth. And those issues don't come into play as much with our trans males. So with our trans males, with the alcohol, with the downers, the benzos, the opiates, they tend to be able to complete treatment at a higher rate. So they can sort of, whilst they may be in a lot of discomfort emotionally, they don't tend to have the kind of outbursts in the same way that our very impulsive stimulant addicts will. With crystal meth addiction, and I speak as a recovering crystal meth addict myself, you know, the impulsivity and the desire to run is that much more present with that drug when you compare it to the others.
Right. Is it safe to say we have a lot of work to do?
Yes.
In that area.
I mean, I think the industry has a lot of work to do. I think the lack of medication is a huge issue. You know, again, one thing you could argue with the higher success rates with alcohol is that they have medications to help with cravings now. There's a raft of FDA approved drugs for both opiate use disorder and alcohol use disorder. There is not a single drug available to prescribe FDA approved for stimulant use disorder. Whilst there are a few in trial stages, which is very exciting, nothing is, available right now. We work with what we have. So with our medical team, we do have detox algorithms that can help with certain symptoms in the post-acute withdrawal period. You know, your sort of typical antipsychotics, mood stabilizers, anxiety medication as well, which can help and be effective, but they're often used off-label for, substance use disorders rather than just generalized anxiety disorder.
Yeah, and boy, are we grateful. Boy, are we grateful that we also work with an incredible medical team, Dr. Collins and Yvette and Dr. Glenn, who really, really navigate that I don't even know how to explain it, but I'm just really grateful that they're there and that they're doing the work that pharma has refused to do. Right. And that's really what's going on here. Pharma has not responded to creating a detox medication for methamphetamine that is so necessary and that would actually help keep people in treatment. So what's next?
What's next? So we, as I just mentioned, we are now partnering with a third-party company, Vista Research. And the reason why is because, as we found collecting this data, it was incredibly time-consuming. We had a lot of dedicated staff members pore over not such interesting Excel spreadsheets to try to get the data that we needed. And also, we're not data experts, so it was also hard to know which data it was the data that we wanted to really pay attention to. With Vista, not only are they tracking the demographic information, the drugs of choice, the kind of stuff, the bread and butter of the data, but they're also tracking a whole raft of outcomes in terms of improvement of symptoms, both during treatment and after treatment. So that's trauma symptoms, anxiety symptoms, depression symptoms. They even track things like the quality of relationships with their families, the quality of their relationship with their therapists, and if they report in their initial surveys disordered eating behaviors, self-harm, suicidal ideation, that all gets tracked too. The great thing with the system is that if those behaviors aren't initially endorsed, that they don't have to come back and deny the same questions over again. And we can also add it in if later down the line that behavior emerges for some reason. And then we can compare that data to, comparable clients who suffer from the same issues.
Right. So exciting. What will all this help accomplish?
Well, the hope is that it improves our clinical work. It will improve our ability to treat clients, ability to help them navigate what can be a very emotionally difficult early period of their recovery. We are already implementing some changes to the curriculum based upon the AMA rates, for example, really looking at, and this is across the board, but as I mentioned before, certainly with crystal meth addicts, is that, the emotional distress tolerance skills are pretty low and need a lot of improving. But honestly, with anyone with a substance or alcohol use disorder, any kind of emotional regulation skill is what they need in the early days. And whilst we do a lot of psychoeducation, I'm going to be honest, I might not tell the clients this, the likelihood of them remembering that in the first 2 weeks of them, detoxing off meth or alcohol is pretty small. However, their ability to regulate is something they may need to do every single day, that they're in a certainly residential level of care. So we've really increased the amount of groups that are focused on emotional regulation and distress tolerance.
Right. So before we move on, let's talk about the completion rate for people that are HIV positive.
So I think that was another area that was of great interest to us when we were looking at the data, since HIV is obviously such an important issue within our community still. So what was surprising to me is that the completion rate for people who come to our facility who are HIV positive was no better or worse than the average. And I think that was a really positive thing. I think clearly the stigma that some people experience with HIV isn't, certainly at a queer facility, something that factors in whether they're going to leave, stay, or an additional pressure that we can't handle. 30% of our clients are HIV positive, so it's a substantial amount, a third of our clients. So it's an important data piece to have, especially considering the clients that are HIV negative who use crystal meth have such a high risk of contracting HIV if they relapse.
Right. And I know that I was watching a video with someone else who works in our space, and I think the percentage of IV users is about 50%, more than likely 50% of of IV users for methamphetamine will become HIV positive. I still am sort of, not, I shouldn't be surprised, but I sort of, it catches my attention when we get someone who's newly infected. And that's why trying to keep people in treatment and really following up and just working harder at understanding the information and how do we get people to stay sober, not to stay sober, but to understand what it means if they go out and they start shooting up again.
Yeah.
So what will all this help accomplish? All this information, what will it all help accomplish?
Lots, I hope. Well, improved clinical care, certainly within our facility and other facilities that work with a queer population, but potentially something that we can teach other people within the field that maybe don't specialize within a queer population, but may have queer clients. I think, unfortunately, people mean well in other treatment facilities, but actually the lack of information about the particular issues that we as a community face, but the community as it relates to substance use, unfortunately, they can do a lot of damage through ignorance. One thing about La Fuente, which is interesting, is that a lot of clients that come to us have failed out of other facilities and have sought us out specifically because we treat queer people only and we understand queer issues. It means that our clients tend to be more highly motivated than others because they have actively sought us out and they have a corrective, more positive treatment experience.
Right. And I'm glad that you brought up that one of the things we also want to accomplish through this effort is to reach out to other treatment centers who necessarily aren't even LGBTQ specific, because we know that the more information they have on how to recognize the things that are very specific to our community, and just as importantly, how to intervene, we know that the outcomes can possibly be better. And at the end of the day, that's what we really want. We want as many people to have the information. I'm excited about what's next. Thank you for doing this with me. We're going to be doing this, I think quite a lot. So again, everyone, thanks for tuning in to Have a Seat, episode 1 with Rory Hunter. And we'll see you very soon.